Well, good morning and welcome back, everyone. This is Larry Boris with the National Association of Worksite Health Centers. I'm pleased to have you part of our session on measurement of health center financial outcomes. We're pleased to have with us John Dawson, Senior Vice President, Chief Actuary of HealthStat, who is responsible for evaluating the financial and clinical performance of HealthStat's on-site healthcare, wellness, disease management, behavioral change strategies, and making recommendations to maximize program value. John's also a member of the NAWHC board. And so I think with his breadth of knowledge and experience, you will learn about a key element of how you measure what we call VOI, or value of the investment you have in your worksite health center. So now, John, turn it over to you. Have a good day.
Thank you, Larry. As Larry said, my name is John Dawson, and I am HealthStat's Senior Vice President and Chief Actuary. Before joining HealthStat, I was a benefits consultant for many years, and I was a benefits consultant with a company called Willis Towers Watson. You probably heard of them, in Wisconsin. And I want to start with a little story about one of my clients. I had a client that was in the road construction business for a long time, and they told me once that they were considering not putting in competitive bids for highway road constructions put out by the state because the state always went to the lowest bidder. They said we understand how to make roads that will last for 10 or 20 years, but the lowest bidder can't possibly bring that technology to the table. We want to be able to do our very best, but if we come in as the lowest bidder, we really can't. And the reason I'm talking about road construction is, we have somewhat of that challenge in our industry. We have sometimes clients and consultants that really don't understand the value. So a lot of times decisions are made based on price alone. And if we're all chasing to the lowest price, our ability to really deliver great value diminishes. So I'm going to talk about financial outcomes today, how to measure financial outcomes. And my hope is that as an industry, we can mature our ability to really show what we do and show the differences between the different models that we have. Now, I am a numbers guy. You can see in my background that I've got a chalkboard, that's a virtual background, but I do like to spend a lot of time looking at numbers and looking at what we've accomplished in things. And rather than looking at, did we at least save enough to pay for our program, I think what's really important is looking at what are we really capable of. And we should be measuring our success based on what could we have done rather than the minimum standard. And I think that if we kind of take that attitude, each of the on-site healthcare providers that are in our industry can start to really show how we're different rather than how we're the same. And we'll be able to show if you really want this, you should go with this healthcare provider. If you really want that, you should go with that one. I want to point out that the National Association of Worksite Health Centers has put together a guidebook on measuring the performance of health. I've got a copy of it here. If you don't, well, by a show of virtual hands, how many of you have a copy of that guidebook? If you don't have a copy, I would encourage you to contact Larry or a member of the NAWHC staff and get yourself a copy. It was prepared with assistance from many different contributors. It's got some really good insights on how to measure performance in a variety of areas, primarily 4 different domains that are shown here. I'm going to focus on the financial domain. And some of the information that I'll be sharing today was drawn from that guidebook. The first thing that I want to start with today is an unfortunate truth. Healthcare is messy. So when we go to measure financial performance, that messiness can get in the way of our ability to really measure what we're trying to measure. Now, what do I mean by healthcare is messy? Well, if you look at your self-insured spend from one year to the next, it's not a straight line. It bounces around for a whole lot of reasons. When you and your consultant put together a benefit design change strategy and you're expecting to save 2%, you might actually save 4%, or it might not save anything. People who are at risk sometimes will have the claims they're supposed to have, and sometimes they don't. And sometimes larger claims occur in people that really didn't have any risk at all. And all of these things make it really difficult for us to really see what's happening when we look at things in a short term. And that means it's really hard for us to look at one point in time and say, is this working? Is our health center actually delivering value or not? You really need to look at things over a longer period of time. And while, of course, we all want to have short wins, we all want to have short returns on investment, sometimes it'll take a little bit longer to see, did the health center actually do that, or were there some other factors? Another thing that's really important is understanding how the health center is supposed to deliver value. And if it's going to take a few years for the savings that you're hoping for to emerge, you want to at least know that the things that have to happen along the way are actually happening. In some cases, we have health centers that do return on investment in the very first year. In other cases, it takes a little bit longer. Sometimes we'll see cost reductions that we can clearly say, we did that, and we can point to the value chain, the things that happened in the health center and so forth that did it. Other times it might not be so clear. I remember a client that we were helping make a decision on an on-site healthcare provider. We had procured about 6 or 7 different proposals from a variety of different on-site health providers. And my team and I had literally spent hours reviewing, analyzing, and preparing for a good review with our client. And as we were sitting down with the client, the key decision maker said, I'm sure glad you guys are here, because I've read all of these proposals and they all sound the same to me. I was astounded because we saw lots of really material differences, but he didn't see it. He didn't understand the value chain. It's really important to understand not only that an on-site healthcare program can deliver some value, it's important to understand how. Now in the guidebook talks about return on investment as a time horizon. How long will it take before the dollars that I save are at least as large as the dollars that I've spent? But very often I see ROI as, let me get rid of that. Very often I see ROI as a ratio. How many dollars will I save for every dollar that I spend over a period of time? And both of these are good ways to look at return on investment. And both of them use the same concepts. How many dollars am I saving? How many dollars am I spending? The dollars spent are really the program cost. And this is the first decision that really needs to be made when we are looking at financial performance. What are we going to include in the dollars spent? Most of the time, on-site healthcare providers that do a return on investment calculation are going to include the cost of the program that they are invoicing to their clients. So implementation costs would include things like furniture, equipment, supplies, and operating costs will include the clinic staff, the labs, drugs and supplies and so forth, and management fees. But when you look at this through the eyes of a chief financial officer, the CFO may say, there are some additional costs that need to be brought into this conversation. Yesterday, one of the speakers talked about build-out costs. Sometimes those are included in the program cost in that ROI calculation, and sometimes they're not. Another possibility might be If somebody from the human resources team is going to spend a fair amount of time working with the health center, then maybe a portion of that person's staff and benefits costs needs to be allocated in. Those are decisions that need to be made up front. The guidebook also talks about different kinds of cost savings and puts them into essentially 3 different buckets. There's the direct bucket, things like reduced medical cost or lower mod rate. Those are things that are relatively easy to measure. And then there's the indirect bucket, things like employee satisfaction or goodwill, and then projected or avoidable savings. And very often, these other 2 buckets are referred to as soft costs or soft savings. But I'm not entirely sure that's a fair portrayal, because they may be soft in the way that we calculate them, in how objective we can be in calculating them, but they are probably not soft, many of them, in terms of how valuable they might be to the organization. And here's what I mean by that. Let's suppose that we could reduce the health plan claim cost by, say, 10 or 15%. That would be really good. But let's suppose that through improved health and improved access to health care, we're able to improve productivity so that the revenue line of the organization increases by just a couple of percentage points. That could be huge. It's just difficult to calculate. So very often we tend to focus on the things we can calculate, but we shouldn't forget about the things that are a little more difficult. Yesterday, David Kite went through a lot of the different considerations that you should make when you are considering an on-site healthcare program for the first time and considering what the scope of services are. And I'm not going to repeat a lot of what he said. I think he gave a really good overview. But there are a few things I think that are really important. When we set out to measure financial performance, the very first thing that I believe that we need to be clear on is, what is our objective? What problem are we trying to solve? If we're looking at a personal health care center, the chief financial officer will probably say, the problem I'm trying to solve is that my health care plan costs too much and it is growing too quickly. And if that's the problem you're trying to solve, then the financial performance measurements we're going to pursue should be related to showing whether or not we're solving that problem. If the problem we're trying to solve is too many reportable workers' compensation claims or a mod rate that's too high, then the financial performance should be focused on measuring whether or not we're solving those problems. And here's where it can start to get complex, because very often we'll have multiple objectives. I've put together a simple example. For those of you who really love numbers, you'll be disappointed because I kept it simple. For people who don't really care for numbers, I hope that this is just about right so that you can get some value out of what I'm going to share. But this is an example of a personal healthcare center. It serves 1,000 members. Let's say they're all employees. And here are the assumptions that we're going to use throughout the example. The program cost, it was implemented in 2018, and the program cost includes some implementation fees. So that's why the cost goes down in 2019 a little bit. And then there is an adjustment for inflation in 2020, so that the program total cost was $700 over that 3-year period. The dollars saved that we're going to use in this example are $450,000 in the first year, growing to 1.2 million by year 3, for a total dollars saved of $250,000. And the net impact, the difference between how much we saved and how much we cost and how much we spent, is $1.8 million. So let's talk about return on investment. When we look at return on investment as a time horizon, we ask, how long did it take to break even? And in this example, we break even in the first year. When we ask, well, how many dollars did I get back for every dollar spent over the first 3 years? That's the ratio of the $2.5 million saved divided by the $700,000 spent. So this program has a 3.6 to 1 ROI. The chart on the right is showing the comparison of the dollars saved to the program cost. We're not going to go into how the program cost is calculated. As we said, you need to decide up front what you're going to include and not include. But we're going to look at a couple of different examples of how dollars saved is very often calculated. This first one, a comparison to a baseline, follows pretty closely how a chief financial officer would frame the problem that we're trying to solve. It says, my healthcare costs too much and it's increasing too rapidly. If we focus on the chart on the right, we see that in 2017, a year before the health center was implemented, the health plan cost was a little bit more than $5 million. And then we're assuming that the cost would increase by 7.5% each year, so that by the end of 2020, the annual cost was almost $6.5 million. Now remember I said healthcare is messy. We know that healthcare doesn't follow a straight line like that. But when we are comparing against a baseline, that's really the best that we can do is know that there's volatility, but over the long term, it does tend to follow a straight line with all of those bumps around it. Now, in this example, we're going to assume that there were no benefit design changes, there were really no meaningful demographic changes, and there were no network changes to worry about. So that 7.5% trend line is fair. If there were benefit design changes or network changes, it might be appropriate to make adjustments to that baseline. In my experience, that's often not done without a lot of support from the consultant that's working with the client. The green line is what the actual claim cost was over the first 3 years. So in 2017, it starts in the same place as the baseline. But in this example, the cost actually went down a little bit in 2018 and then increased a little bit in 2019 and 2020. The difference between that trend line and the actual claim cost is the claim cost reduction, which matching the example on the previous page grows to $2.5 million. Some things that you need to be cautious about when you're using this approach is making sure that you have a clear agreement on what the baseline is and what the trend is. And if you're going to have a financial performance guarantee based on this type of financial calculation, you're going to want to agree on how do we calculate that baseline up front. Typically, we will know what the claim cost per member per year is when we are inking the contract. You're also going to want to adjust for outlier claims. So a lot of times, the thing that drives most of the volatility from one year to the next is how many large claims did I have. One year you might have 3, the next year you might have 1, and the year after that you might have 5. And it'll be really hard to see, is the health center actually delivering value because those large claims are shrouding everything. When I was a benefits consultant, I had a hard time with the idea of taking those large claims out because they're one of the problems that I wanted to fix. But with a good on-site healthcare program, we're not going to ignore large claims. But what this calculation is trying to demonstrate is when we set the large claims aside and we look at things that are going to happen over and over and over again, the routine stuff, the health center is actually reducing cost for everybody else. And we'll do what we can to start reducing the number of large claims over time through health improvement. This next method is an interesting one. We use this in our new vitals report. Um, it is a way of showing how we are actually achieving a cost reduction by comparing to a reference group. And there's an awful lot going on this page, but I think it's really important to understand how this works. So if we look over here on the right-hand side of the page, we can see the number of health center users. Remember, this is a group of 1,000 employees. So this is pretty good participation rate. We got a 70% participation rate in year one, 700 users, growing to 750 in year two and 800 in year three. One of the things that we very often see, unless you've got an effective outreach program, the people who will use the health center tend to be the healthier people. With a caveat, I have two columns here. We got non-health center users and health center users. But there's actually a third component that I might want to break the non-users into. Within non-users, there are people who are using healthcare, but they're just not using the health center. And then there's people who aren't using any healthcare at all. And those people they need to be handled separately. When we do this kind of calculation at HealthStat, very often we are comparing health center attributed users, people who are choosing to receive their primary care through us, versus people who are attributed to a community-based provider. So at least we're looking at people who are utilizing healthcare. The problem with people who aren't utilizing healthcare, when we think about risk scores, is that we don't know a whole lot about them. Most of the risk models that are used to calculate risk scores are going to use factors like your age and your gender, but they're also going to use information about your claim costs, your diagnoses, and the kinds of procedures you've had. And for people who have not had any health care at all we really know is their age and gender. So think about an obese 45-year-old who is pre-diabetic but doesn't know it, who has hypertension but doesn't know it. The risk model is going to look at that person and say, it's a 45-year-old male, and is going to assign a risk score based on that. But if the risk model knew that it was a 45-year-old male that was pre-diabetic and hypertensive, you would get a much higher risk score. So we really need to be cautious about how the risk scores are calculated and how we're handling those people who don't have any claims. In this example, with about 70% of the people utilizing the health center in the first year, we're assuming that the health center users are a little healthier than the non-users. As we get further into the participation, we reach parity, and at some point, the health center users cost a little bit more than the non-utilizers. And I'll show you why that's important in a minute. Next, let's look at the claims per member per year. We have claims for the non-users starting at $5,914 and growing to $6,400 by the end of the third year. And then we have the health center users whose claim cost is less. Now, it might be tempting just to compare these and say, gee, the health center seems to be saving about $1,200 per person in that first year, but that wouldn't be fair because the people who are using the health center do have lower risk. So we would expect them to cost less. So in this method, what we'll do is we'll take the non-users who have an average risk score of 1, and we're going to multiply by the ratio of the risk score for the health center users divided by the non-users and come up with a risk-adjusted cost for the non-users. Then we can compare that to the health center users to see what the indicated claim cost impact was. And what we're doing by doing that risk adjusting is saying, if the non-users had the same risk level as the users, we would expect them to cost $5,300 instead of $5,900. We do the same thing in the second year, but since the risk scores are the same, there's no adjustment. And in the third year, the adjustment actually increases the claim cost from unadjusted to adjusted, because now we would expect the health center users to cost more. So we've calculated the per member per year impact using the risk adjusted claim cost method, multiplied by the number of health center users, and there is your $2.5 million of claim cost reduction. So as I said, it's really important to understand how these risk factors are calculated and how the non-health care users are treated in this. Otherwise, we may be actually understating the risk score of the non-users because we don't have enough information. And sometimes the users and the non-users are so different that even a risk adjustment doesn't make for a fair comparison. But the healthcare providers that use this method, I have to believe they're trying really hard to make sure that they're portraying things as fairly as possible. One other thing to be concerned about, though, is let's suppose that you do this kind of analysis and it shows that you saved $2.5 million. But when you compare your actual claim cost to your baseline, instead of being down here, if it pretty much is following the baseline, the chief financial officer is probably going to say, I don't believe that you're saving me $2.5 million because I'm not seeing it on my profit and loss statement. So I think this is a good way to maybe explain how we're saving money mathematically, but it isn't necessarily the final way that you should look at whether you're saving cost. Another method that I see, and this one is one that a lot of insurance consultants think is really the only way that on-site healthcare can save money, is diversion of care. And diversion of care may be the right and only approach if what we're talking about is an acute episodic healthcare center or one that is focused on workers' compensation claims. Because in that case, what we're really doing is taking what was going to be spent anyway and moving it into a lower cost setting. But if the health center's focus is also on improving safety or also on improving health, then the diversion of care approach doesn't really explain the whole situation. But let's see how this works. So the calculation is fairly simple. We compare the cost of receiving a visit in the community with the cost of receiving a visit in the health center. The difference in this example is $106. We multiply by the number of visits, and there you have your annualized impact. Sounds pretty easy. There are some problems, though, that we need to talk about. Where does the community-based cost come from? Sometimes I see that cost coming from the healthcare blue book without any adjustment for network discounts or any adjustment for benefit design. That probably would be overinflated. Sometimes it comes from the health plan. So the network discount and the benefit design has already been taken into account. It's important to make important decisions on how are we going to calculate that community-based cost. If my focus is on saving the health plan dollars, then we probably need to adjust for benefit design. If my focus is on saving dollars for the health plan and employees, then maybe looking at the discounted cost might make sense. To come up with the average cost per visit for the health center, we take the program cost, divide by the number of visits, and that produces an average cost per visit. And then, of course, the number of visits are shown here. A couple of things to be concerned about there is induced demand. If, let's say, 20% of these 2,100 visits wouldn't have happened if the health center wasn't there, then we've overstated the annualized impact, because you can't divert visits that weren't going to happen in the first place. And as I said, that this method really misses an awful lot of what an on-site healthcare center can actually accomplish. Let's talk a little bit about productivity gain. In the United States, when we talk about healthcare, we're really talking about healthcare cost. In other countries, when we talk about wellness programs, their focus is primarily on improving productivity. Here in the United States, a lot of employers really haven't wrapped their head around the productivity piece yet because the healthcare cost just seems so enormous. Now, as we get into this, one should understand that there are two different kinds of productivity gains, or two different factors that can lead to productivity gain. We're going to show the calculation of productivity gain related to making healthcare easier to access. But the other kind, and probably the bigger kind, is productivity gain related to health improvement. So let's see how this works. We've got our utilizing members, 700 in the first year, growing to 800 by year 3. Average number of visits, we've got our annualized visits here. That's the same as what I used in the diversion of care example. Now, when somebody leaves campus to go get healthcare in the community, very often they're going to be gone for 3.5 hours or more. But if we can get somebody in and out of the health center in a half an hour, get them back to their workstation, we've essentially saved 3 hours. So if we multiply that 3 hours by the 2,100 visits and then divide by 2,080 hours in a full-time year, you can see that in this example, we saved a little more than 3 full-time equivalents. If we can agree on what an hour is worth, we can multiply that value per hour times the number of hours saved times the number of visits, and we can turn that into an annualized amount. Now, some employers will say, gee, when somebody leaves campus to go get healthcare, I make them take paid time off for that, so that doesn't cost me any money. And that may very well be true, if that absence was sufficiently planned so that you can address the fact that the person's not at their workstation doing their job. If instead that absence is really more of an unplanned absence and productivity wanes because they're not there, then maybe there's something to this. But productivity is really difficult to assess because not only do we have to figure out how many hours are we talking about, what's the value per hour, we have to figure out how does the employer react to the lack of productivity? How does the employer react to presenteeism and absences? In some cases, employers will hire redundant workers because they need more bodies to do the same job. And if we can provide productivity gain, those employers can reduce staffing because they don't have to hire redundant workers. On the other side, some employers accept, not willingly, but they accept that they're not going to make as many widgets as they had planned because their people just aren't as productive. So their productivity gain is seen as increased revenue. And those are two very different things. And then we have other kinds of employers, such as, say, a school system, where improved productivity may not directly impact the financials of the organization. A math teacher who is there all the time, but not a very good math teacher because they're struggling with some health conditions, provides a poor educational experience. If we can help that math teacher to become a healthy person, the educational experience will improve, but it doesn't necessarily have an impact on the organization's cost. Now, I said there's another kind, that's the health improvement part, and the Integrated Benefit Institute published a paper a few years ago that indicated that whatever we save on the health plan through health improvement, productivity is probably worth 2 to 3 times as much. So how do we evaluate that? Check and make sure I'm doing okay on time. Back in 2012, HERO commissioned a study. It was led by Ron Getzel and a team of specialists to look at modifiable health factors and see what impact we could have if we could modify those health factors. Ron Getzel is one of HealthStat's strategic advisors, and I've had a chance to talk with him about this study. He says one of the biggest challenges with measuring the impact of health improvement is double counting. Because very often people in the wellness space will say, well, I was able to get somebody to a good BMI, and that's worth this much money. And then here are my hypertensives. I was able to get this percentage of them to a good blood pressure, and that's worth this much money. And here are my pre-diabetics that I help to avoid getting diabetes. That's worth this much money, and so on and so forth. And when you look at it, very often they're measuring the same savings on the same people through different lenses. What this study was intended to do is try to isolate out how much is each of those factors worth, knowing that we are counting the rest of it in other places. So these are the factors they looked at in order of priority. Depression was number one, and once they take out all of the claimed savings available by addressing depression, then they looked at high blood glucose. And once they take out all those, they look at high blood pressure. And by the time they got to the bottom, total cholesterol, nutrition, and alcohol consumption didn't have any savings left. So in their study, it actually looked like it would be protective to have high cholesterol, eat bad, and drink a lot of alcohol. Well, we know that's not true. But their study was intended to, once we start looking at people, we don't have to worry about double counting. They also showed these 10 factors were responsible for about 22% of the overall spend. Now, there are other studies out there that say 70% of our healthcare spend is attributable to bad behavior, or 84% is attributable to chronic disease. This 22% seems small compared to that. But the big takeaway I want you to have is when somebody is showing you, here's how much money we're saving on health improvement, make sure that there's not a lot of double counting going on there. Health improvement is really what we all want, but we want to make sure that we're not overcompensating for it. Now, as Larry was introducing this session, he mentioned value on investment. HERO is one of the organizations that has really been helping employers move away from looking at return on investment only and look at value on investment as a broader measure of, is this really working? And there's many different reasons for that. One reason is reduced healthcare cost is only one of the many things that an on-site healthcare center can deliver for an employer. If we can get people more engaged in the job, that's certainly something that's valuable. And we can go down that path. The other path is some of the financial impact that we see takes some time to develop, but if we understand the value chain, we know what needs to happen early on, and we can start measuring those things to be able to show that this is working, even though the financials may not quite be there yet. But value on investment, I think, is a really important concept that we need to be looking at. ROI, yes, it's important, but let's make sure that the health center is hitting on all of the cylinders and not just that one. And that's one of the reasons why we've incorporated several different measures beyond just financials in our new online reporting system that we call Vitals. And we set this up to basically tell a story. We want to make sure that patients have a great experience and give us high satisfaction scores, because if the patients like what we do, they will come to the health center. And when they come to the health center, we can reduce gaps in care. And when we reduce gaps in care and make people, help people to be healthier, then we have an opportunity to save money and on and on and on. Value on investment gives us a much broader perspective than just, are we saving money or not? And last, I'd like to spend just a few minutes on performance guarantees. This is just my personal bias, but I believe that if your on-site healthcare provider says that they're going to do great things, that you should be able to hold them accountable for that. And you should be able to hold them accountable for the great things that matter most to you. Performance guarantees, when they're set up right, can provide you with some safeguards against what happens if it doesn't work out so well. But some things to really be cautious of is you want to make sure that the performance guarantees are well defined, so everybody agrees on what has to happen in order for this performance guarantee to be met. And you want to make sure that the performance guarantees don't have a lot of contingencies that essentially make it pretty much impossible that you'll ever get payment. At HealthStat, we put up to 100% of our management fee at risk. And we generally allow our customers to put the risk levels at the places that matter most to them. And I'd love to say that we've never paid out on a performance guarantee, but we do. We're not perfect. And we think that when we make a promise and we deliver, we should all celebrate together. If we make a promise and we fell short, we shouldn't hide behind contractual language. We should make it right. And I really would like to see all of the providers in this space behave in a very similar way. So those are my prepared remarks. And Larry, if there are any questions, I'd be happy to take them in the next few minutes.
John's been very comprehensive. You did a fine job on that. Again, I would ask anyone who wants to submit a question, please do it on either the chat or the Q&A feature, and John will be able to respond to that. If it comes in after the session closes, we'll have John respond back to you. We did have a question about how to obtain the NAWHC guidelines for measuring the performance of worksite health centers, which does include many of the areas that John talked about. If you go to our website, you can order it there. Members of our organization gets a free copy. Otherwise, it's $125, and you can send an email to membership@nawhc.org to order a copy for you. John, we had somebody who did ask, could they try to get a reduction in their stop loss coverage if they can show the performance of their health center was high enough so that there were less risks and less problems in that? Or is that just one of those street line myths?
It is not a myth. There are some stop loss providers who understand how on-site healthcare works, and they are willing to make some concessions because, as long as they can see that the on-site healthcare provider that you're working with does deliver value. There are some stop loss providers that will not do that. They feel they don't have a need to do that. They've got name brand, and employers will buy from them regardless. But there are some stop loss carriers, some underwriters that have really gotten into that space and are making some concessions.
Great, thank you. We had a question about whether people would get a copy of the presentation. Yes, this has been recorded, and it will be sent out to all of the attendees of the forum, and then the copy of the slides are available as well. And John's would be also available at HealthStat for anything else you'd like to ask about. John, I may have missed it, but I know you mentioned something about the time that people take off work. Is it valid to say, all right, we average 3 to 4 hours when someone leaves work to go to a doctor or physical therapist, et cetera, and by having them on site, we can just multiply the average salary of employees times 3 hours, and that shows our savings? Is that a valid approach?
That's the approach that I showed. Let's go back to that slide quick.
Okay.
So it's not shown on here, but when we look at people leaving campus to get healthcare, they are going to be gone about 3.5 hours. That varies depending on where you're at. If you're in a fairly rural area where the nearest healthcare provider is a long ways away, it might be more than 3.5 hours. Or if you're in a metropolitan area like New York or Los Angeles, where it takes 15 minutes to drive a mile, it could take you much farther. or there's other places where healthcare may be more accessible. But on average, we see it takes about 3.5 hours once people leave. So compare that to getting somebody through the health center and back to their workstation in a half an hour. That's where the 3-hour savings comes from. Is that your question?
Well, can you just multiply that by the average salary of all employees, or do you have to segment that in some way?
When we do this calculation, a lot of times we'll use average salary as a proxy for what an hour is worth. But in reality, if let's say your average salary was $50,000 and that's what an average value was worth, the company is going to go broke because there's no margin for them to make money on that employee to pay for rent and pay the lights and pay taxes and so forth. So the real value per hour is something that the employer may have a sense of when they've done some of their workers' compensation analyses, or it may be something that a productivity consultant can really opine on. We're generally fairly conservative and use the average salary as our proxy for calculating what an hour is worth.
Well, thank you very much, John. We appreciate your time.